that. Another thing that I'd like you to know is I think being an excellent general dentist is the hardest job in all of dentistry. With all due respect to my specialist colleagues, I've chosen a profession, an area in the discipline that requires that I be fluent in all different areas of dentistry. And so it's exceedingly challenging to be fluent in all those disciplines. So bear with us when we don't know everything that you do, but we do have a problem that's greater than yours. Yeah, we have a Heisman Trophy winner in Texas this year for the first time in a while, since actually at Texas A&M University, where I paid 9 years of tuition. Anyway, the point here is this. As a general dentist, as a restorative dentist, as a primary care guy, I happen to be the quarterback of my dental team, and I have to act accordingly. I have to be able to call the plays, and I have to assign plays, other parts of the game, to my specialty teammates, okay? So, this is another epiphany that I had. I realize now that I'm the gatekeeper to the care that my specialist partners can provide. If I don't work and practice and treatment plan at my highest level, you don't get a chance to do that either. So it's extremely important that all of us collectively as a team realize that we're elevating each one of us. It's not just one that benefits from the game, okay? So let's go back to Lydia. Let's see what happened. Who's on my team for Lydia? Well, obviously me, the restorative dentist. And who else would I need? Thoughts? A periodontist, maybe? And an orthodontist, right? Okay. So this is what we did. In treatment planning, typically what we do is we develop a problem list. And from that problem list, we're able to create a diagnosis. And with that diagnosis, then we can ultimately assign treatment for the case for our patient, okay? So if I send Lydia to the periodontist, Eric says to me, well, here's Lydia's problem list. She's got short clinical crowns anteriorly and posteriorly. She has missing tooth number 6, the extraction of which occurred very early in her life, which left the resultant buccal ridge defect, which needs to be dealt with. And she has limited access for oral hygiene. I already fessed up and told you that's the reason that I sent her to Eric in the first place. It helps when you have a periodontist who's more fluent in restorative dentistry than most general dentists are. And that's my friend Eric. He says she's periodontally stable. I sent her for an orthodontic consultation, and this is a problem list. Class 2 malocclusion, a deep bite. She has a midline discrepancy. And she has dentoalveolar extrusion secondary to occlusal wear. You're going to learn about that from Bill when he goes through his global diagnosis later. I think Bill says he could spend an entire day talking about DAE. So what did we do? What sort of treatment did I render to Lydia, did we render to Lydia that helped her out? Well, first of all, we did some initial periodontal treatment and orthodontic therapy, okay? And here are the results of that treatment. Her midline discrepancy is corrected, her deep bite is corrected, her arches are leveled and aligned. You can see right now from this view that the buccal exostoses are gone. The functional crown lengthening that's been performed in the posterior reveals a lot more tooth structure. Remember, you couldn't even see the margins of those crowns early on, right? So there's an occlusal view, arch is in perfect form there. The mandibular view, look at the amount of bone that we were able to take away to give Lydia the access for oral hygiene that she needed. So here's Lydia at the end, and I'm thinking we're just ready to put crowns on. So here's her in repose, here's Lydia in repose, and here's Lydia when she smiles. Not real attractive, right? Well, all of you in the audience now that have been through the training and everything that you've been through recognize the fact that you can't feel the CEJs on those teeth when you explore them. And Lydia has she has altered passive eruption. So one of the things that Eric did was take her back to surgery again. And this is the surgical procedure that Eric did in order to modify the position of the bone above the CEJs of the teeth in order to maximize the gingival position, maximize the amount of tooth structure that's displayed. And 2 weeks post-operatively, Lydia looks like this. And you can actually see the change in tissue level just because of the shade of her teeth. But we gained about 3.5 to 4 millimeters in tissue level. So now I'm set up perfectly to do my job, which is to complete the restorative dentistry. So the restorative diagnosis and provisional restoration took place in the maxilla. This is her slightly open, so you can still see the amount of wear that is present on her maxillary anterior teeth, as well as the amount of wear on her lower anteriors. I think I need more length of those teeth. So I'm going to take a leaf gauge, and with that leaf gauge, I'm going to open her vertical dimension arbitrarily to a certain point where I can then see that with diagnostic wax-ups and restorative dentistry, I'm still going to be able to couple things anteriorly. And from that, we mounted it on a semi-adjustable articulator, and we were able to complete a full mouth diagnostic wax-up. This is representative of the maxillary portion of that. I went back and I did the full maxillary preparations. And these are the provisional restorations that I created, chair side. So now I'm happy with the occlusal view, basically the aesthetics in the incisal edge position, the occlusal plane, everything about the maxilla I'm happy with. The next step of the game is Eric's going to come in and place an implant in the position of tooth number 6 with the simultaneous connective tissue graft in order to be able to correct some of that buccal ridge, the buccal defect that's there on facial number 6. And so surgically, Eric placed the implant in number 6 and did a pedically, a connective tissue graft which maintained a pedicle in the palate, which maintained vascularity. It was basically transitioned over the implant and underneath the donor site on the facial side. And this is the immediate post-surgical view and the sutured view. Okay? So we won't belabor the long post-op that occurred there, but essentially what we've done now is, let me just explain how this happened. While the implant is integrating, while the soft tissue is healing, while everything is going on in the upper, since I'm happy with the upper restoration, the provisionals, then I can build the lower to those upper provisionals, which is what we did. And then after everything has been healed well enough, I do the posterior rehab, I do the posterior restorations, and finally go to her anterior 6 teeth. All right? So this is now just a photograph of the anterior 6 that's prepped, the implant you can see in the position of number 6. And there is our postoperative result. Okay, that's the full facial view of Lydia's case. The right buccal view, obviously the implant number 6. The left buccal view. The occlusal view, these are all ceramo-metal restorations. These are all porcelain bonded to metal. And then finally the mandibular, as you can see. And Lydia is one happy gal. And I'm thinking, I got this stuff wired, baby. I know how to do it now, right? I did it with my team, I did it together, and I think that I'm proud to show you that result. I think it's an outstanding result, aesthetically, functionally, everything about it. So I would suggest to you that it's perfect, right? Well, come on, somebody go with me on this. I feel like Gary Zaleski yesterday.
Got an airway issue.
Got it. Okay, don't get ahead of me. I didn't want you to get that good. Wrong. Absolutely wrong. It's not perfect, okay? It isn't perfect. So let me show you what I would do, okay? What's wrong with it? What would I do today? Well, the first thing that I would do today is I would use a global diagnosis format. If you think about that case and how I went through the case, it was a little bit haphazard because I didn't come up with an initial diagnosis immediately and a final plan that we're going to follow in order to be able to achieve the outcomes that we're looking for, okay? When you listen to Bill later, he's going to talk about global diagnosis. I'm not going to steal his thunder. I can't. I'm not nearly smart enough to do so. But I will tell you that Bill's going to talk about some core questions that you ask of yourself, and you write down values. You record values for those questions, and depending upon their deviation from the norm, you can make a diagnosis from that. So everything that we do can ultimately come from a diagnostic position and a more sequenced, intelligible, logical treatment plan. So based upon that, what do you think I would have done as far as changing my treatment plan? What glaring error is in there Nobody? Jeff, you can say it if you want to. Aesthetic crown lengthening surgery should have been done prior to the completion of orthodontic treatment. Why? Because if the CEJs were not at the proper level, the soft tissue would have healed at a wrong level. And my risk was, if that's the case, the aesthetics of the case are totally blown and we have to go back to orthodontic treatment again. All right? So, with a global diagnosis format, it's a logical sequenced approach to enable me, the practitioner, the restorative guy, to make a plan that can prevent some of those problems, okay? Yeah, I know, Jeff. Everything is the airway. Jeff is turning my world and the dental world upside down with his knowledge and research and his presentations on airway. The next program that you're going to hear is a game changer, and I think it's very definitely, as one of you said here in the front, airway should have been considered. Well, this was before I knew anything about sleep apnea or sleep disordered breathing, okay? But in today's world, I said to you, what would I do differently? The answer is I would definitely screen her for sleep disordered breathing, and I'll let Jeff tell you about what can be done about that prior to restorative dentistry. There's other things that I would have done differently, but those are two very glaring things that I think would have changed with the help of an interdisciplinary team and a little bit more knowledge at this point in my life, okay? So, the last bullet point, my last left brain number is, what are the benefits of providing interdisciplinary care? Are there any? Well, I'd suggest to you that I'm different today. And I'm different today in many respects. One of them is I'm more fulfilled professionally. I'm happier with what I do. Those days of me dentistry have turned into days of we dentistry. And we dentistry is a heck of a lot more fun. It's a lot more satisfying. The care that I provide, that my team and I provide, my own dental office team as well as my interdisciplinary team, the care that we provide is more technically challenging, which adds to that professional fulfillment. It makes me want to do more, makes me want to get better. I don't talk about money. It's not my thing. It's not why I get up and go to work every day. But I will tell you that my practice is significantly more profitable since I've been involved in interdisciplinary care. All right? I don't go to work trying to make certain numbers, but the reality is if I treatment plan patients properly and for what they need, then ultimately my practice has been more profitable. I'm a little bit above Michael Cohen on the enthusiasm scale. Just a little bit, Michael. And I'm more enthusiastic about dentistry, and as a consequence of the non-clinical program, I'm a little bit more enthusiastic about life. I would suggest to you that my team is more enthusiastic about dentistry as well, okay? So because you see, there's something that's a burden associated with this game called leadership. And that burden is that as we go, the people we lead, so go the people we lead. All right? Remember I said I look in the mirror and it's me? The leadership thing says it's me? Well, I came to the realization that that was necessary. So here's my team before interdisciplinary care. Truly. I used to come in and I would complain, gosh, my team, they just don't get it, you know? It's like they don't like working here, they don't like it. Look in the mirror. It was me. Reaching our potential creates an environment for others to reach theirs. Huge. Very, very important. The harder I work to better myself, the better people around me that help me do that become. And so I would suggest to you that this is my team now after interdisciplinary care, after adopting interdisciplinary care, okay? They're far more enthusiastic. They want to come to work, and good people want to work for good people. So you'll find difficulties associated with finding great employees is lessened because they find out about you and they come to work for you because of the reputation that you have. So anyway, that's my team now. And I have one final confession to you this morning, and that is this. Probably 95+% of the time, I'm still a single-tooth dentist. Why? Because not all of my patients need interdisciplinary care. All right? Not all of my patients can afford interdisciplinary care when I recommend it to them, when I have them when I treatment plan it. But I would tell you that I have the ability to recognize it, I have the ability to treatment plan it, and I have a team working with me that's phenomenal at helping me achieve the outcomes that I'm looking for. So that's my final confession to you. And I would like to tell all of you directors that I am not special. You have members in your group that can do the exact same thing that I've done. There's only one thing they have to do in order to accomplish that, and that is they just have to get out of the yard, okay? Like that dog, you just got to get out of the yard. So anyway, let me wrap up with a quote from a guy I consider my mentor. I told you to get his book. It says, "Strive for the self-satisfaction that always comes from doing the best that you can to become the best of which you are capable." Happiness basically is the journey. It's attempting to be as good as you can possibly be. Maximize your potential, and personal satisfaction will follow. I showed you my professional inspiration. I have 56 seconds to show you my personal inspiration. This is my wife, Evelyn. There's one error in this photograph, and that is that it would appear as though I'm carrying Evelyn. The fact is, for the last 32 years, Evelyn has been carrying me, okay? So she blessed me with 3 kids, and it's cool when your kids bring home cool kids. So she told me when we first got married she wanted 6 children. I said, no way in hell, I'm going to father 3 of them, and you can find the other 3. Well, she got her 6th child, which is the gal on the far right, when our son Clayton got married December the 1st of last year. And this is the ultimate reward for parental survival. This is Charles Arthur Marley, AKA Cam, my first grandchild that was born 11 days ago. So anyway, let me wrap up. Thank you. Let me wrap up by saying thanks to Michael for his vision 20 years ago. I mean, you've definitely changed my ability to do what I do on a basis that's higher than I ever could have achieved. And I also want to offer my personal and heartfelt thanks to a guy, Eric Rindler, who's my study club director. You've changed my life. Thank you.
That concludes this program. This material was recorded and produced by Mobile Tape Company, Incorporated of Valencia, California. More information about other available media may be obtained by calling 1-800-369-5718 or on our website, mobiletape.com.